All right, good morning, everyone. My name is Janice So. I'm a professor at UCSF School of Medicine, Department of Psychiatry and Behavioral Sciences. I am so excited today to be your facilitator for this e-poster session. We have altogether 7 e-posters on the topic that I think we all care about is on COVID-19 and health effects. And my co-facilitator today is Brava Sanchez. And thank you for co-facilitating with me today. So Brava will be helping us to keep track of our time because we all together will have 7 posters. And also we will only have less than actually 50 minutes after I talk to the introduction. So each presenter will have 6 minutes to present your work and to discuss further. And I know many of you would have questions for each other and for the presenters as well. Please use the chat and then we will do our very best to squeeze in at least a question or 2, but we will going to do it within our 6 minutes here. And toward the end, I hope all of you will stay until the end and then see if we would be able to use our last few minutes to share any insights or, kind of additional thoughts about the research area. Okay, so we may be switching back and forth between screen and all presenters. If you have preference in terms of sharing your screen, make sure you let Barbara know. Otherwise, Barbara will be sharing her screen for your poster. All right, so let's get started. Our first presenter is Deanne Gu, and her presentation today is titled Race, Ethnicity, Primary Language, and COVID-19 Hospitalization in the Context of COVID-19 Vaccination Status. Deanne, the floor is yours.
Okay, so can I share my screen?
Yes, you can, if you are ready to share.
Okay.
All right.
So, hi, I'm Dean. I'm a postdoc fellow in the Center for Tobacco Control Research and Education. My research examines the association between race, ethnicity, primary language, and COVID-19 hospitalization in the context of vaccination status. This work is supported by the National Cancer Institute and the National Institute on Drug Abuse. Dr. Zhou is my mentor on this project. So there have been many studies about the race ethnicity disparities in COVID-19 vaccination and COVID-19 outcomes such as hospitalization. Language barrier is a source of health inequities. However, the association between race, ethnicity, language, and COVID-19 outcomes in the context of COVID-19 vaccination status has been understudied. This study is to supplement the research gap. Data source, we used electronic health records from 14,667 COVID-19 adult patients tested positive between Feb 1st, 2020 and Jan 21st, 2022 at the UCSF Health. The dependent variable is COVID-19 hospital admission. Is defined as hospitalization within 14 days of the first positive COVID-19 PCR test and or having an ICD-10 COVID-19 diagnosis at admission within 45 days of the first positive COVID-19 test. The primary independent variables include race, ethnicity, language. Covariates include age, gender, health insurance type, smoking status, the Charlson comorbidity, time periods in reference to vaccines availability, and the vaccination status. For the analysis, we conducted 2 multivariable logistic regression models with COVID-19 hospitalization as the outcome. Model 1 didn't include vaccination status, and in model 2 we added. Okay, so let's look at the patient's characteristics. As you can see in table 1, out of nearly 15,000 patients, there are about 5% were admitted for COVID-19. About half of patients were non-Hispanic white, 20% were Hispanic, and 15% were Asian, 9% were non-Hispanic Black. There were about 7.6% or slightly over 1,100 patients who were English speakers. Actually, the top 5 non-English language were Spanish, Chinese, Russian, Arabic, and Vietnamese. I didn't show it here. Figure 1 shows a proportion of COVID-19 hospitalization by race, ethnicity, language, and vaccination status. There was a significant variation in hospitalization across groups. Notably, non-English patients had a much higher hospitalization rate than the others. Figure 2 shows the results of the 2 multivariable logistic regression. Model 1, on the left, we can see that about adjusting for the vaccination status, a non-Hispanic Black had higher odds for hospitalization than Hispanic and non-Hispanic White. Hispanics, non-Hispanic Asian, and non-Hispanic others odds for hospitalization were slightly higher than non-Hispanic White. Non-English speakers also had higher odds for hospitalization. After the adjustment on the right, you can see, as shown in Model 2, the difference in hospitalization between non-Hispanic other and non-Hispanic white and non-Hispanic Black and Hispanic minorities was eliminated. Non-English speakers remained have higher odds to be admitted for COVID-19. So what are some of the takeaways from these findings? First, the findings highlight an inequity gap in COVID-19 related health disparities, particularly among non-English speaking and ethnic minority patients, which needs urgent attention. Second, these findings also call for increased efforts in providing culturally and language appropriate healthcare services to address these disparities. Okay.
Thank you very much, Deanne. How much time do we still have left, Barbara? That within 6 minutes.
We have about a minute and a half.
A minute. Okay. Okay. So any questions for Deanne and then for her work? And then also a note for all the speakers as well as later when you present yours, sometimes actually we may not be able to see the focus very well. So just FYI, if you decide to share your screen.
Hi, Diane, this is Gray, and it's a very interesting study. And so I see you use the UCSF EHR data. So as we know, the EHR is highly selected, maybe people with higher incomes or higher socioeconomic status, they are more likely to have the EHR record. So what would you expect your finding to be generalized to the general populations?
Maybe just generalizable to UCSF patients. And actually, this EHR is part of the COVID EHR cohort of the University of Wisconsin project. So the University of Wisconsin collected the EHR data from 21 health systems in the United States. So UCSF is one of them.
Great, thank you.
Thank you.
Thank you for the great question. And then, maybe may I add, like as shown on the table one here, it looks that we have half of the patients here are on public health insurance. So in some way, while it's limited, it is actually pretty diverse, surprisingly, for UCSF health patients. But every UCSF health patients, despite their background, each patient does have an EHR record, just for all of our information. All right, so in this case, we are going to go to our next presenter. Our next presentation will be presented by Dalia Kaki. Her presentation title is COVID-19 and Telehealth: Refugee Perspective on Hypertension Management During a Pandemic. Dalia, I hope I pronounced your name correctly.
Absolutely correctly. Thank you so much, and I'm so excited to be here. So I'll kind of walk us through. I'm hoping I'll probably buy us back a little bit of time because this is a pretty straightforward project. This study was done as part of a larger intervention study that's being conducted at UC San Diego to implement a self-monitoring program for hypertension amongst refugee populations. San Diego is one of the largest refugee resettlement cities in the United States and the largest in California. And a majority of the refugees in the recent past have come from Arab countries in the Middle East, primarily Syria and Iraq. Cardiovascular disease is a very common chronic illness amongst refugees generally, but specifically amongst Arab refugees. And uncontrolled blood pressure is one of the largest risk factors for that experience. And as with many patient populations that are being collaborated with in this symposium, refugees experience persistent disparities in cardiovascular disease outcomes, which is why this sort of work is quite important. I want to caveat my whole speech by saying that the population refugee is kind of a misnomer, because refugees are incredibly diverse, come from a lot of different ethnic and racial backgrounds, and so it's very difficult to kind of lump everyone into one category. In this study specifically, we talk about Arab refugees, and so that's the kind of nomenclature that I'll be using. The COVID-19 pandemic obviously limited access to care for everyone, particularly for vulnerable patient populations, refugees included, and lots of studies have shown that racial and ethnic minority groups have experienced worsening hypertension control during that time. The use of telehealth is something that has kind of a mixed bag in terms of pros and cons. And so it's really helpful for ensuring continuity of care for a lot of folks, particularly in pandemic settings and low resource settings, in rural settings. However, technology access isn't equitable, and disease management can be really challenging for folks who don't have access to internet, who have low tech literacy, who don't have the kind of socioeconomics to be able to afford the technology needed to engage in telehealth modalities. And so disparities kind of play a significant role in telehealth uptake amongst our Arab refugee population in San Diego. So this study was kind of an offshoot of a larger study looking at hypertension management for like self-titration of hypertension medications amongst refugee populations. It's kind of a growing trend in hypertension management care, trying to get participants or patients in general to kind of have a more independent role in managing their blood pressure. And so we wanted to do a feasibility study to kind of get a sense of whether our refugee population in San Diego would be willing to do that kind of intervention, what their perspectives are. And as the COVID-19 pandemic happened, we added a few more questions onto our project to kind of assess their comfort with telehealth, which was the primary modality through which we were going to be running this intervention. Ironically enough, telehealth then became a huge part of the COVID-19 pandemic healthcare delivery system. And so we decided to combine those questions together. So this was a qualitative research study with 109 participants who were recruited through a local federally qualified health center, as well as a local community partner that serves this patient population in El Cajon. The participants were interviewed between April 2021 and 2022. They were interviewed in Arabic. All the translations were done by professional interpreters. And then we had everything transcribed so that we could do some qualitative analysis. And so our results showed that a huge majority of participants used telehealth modalities at least once during the pandemic. Our three kind of main outcomes was that during COVID, the social isolation really worsened the kind of mental health, the already kind of vulnerable mental health state that our participants were reporting. And that kind of worsened mental health really affected their motivation to manage their blood pressure. It really affected their motivation to participate in their care. And as a result, they had worsening blood pressure readings, which I didn't include in this poster, but many of them reported kind of increases in their blood pressure readings during the pandemic. Our second kind of main theme was that telehealth really did alleviate some discontinuity of care, as we saw with many patient populations. However, it posed significant logistical challenges. As I mentioned before, there was challenges with access to care and connecting to Zoom and Wi-Fi and whatnot. And also there was cultural challenges that amongst this Arab refugee population, many thought that it wasn't as good quality of care. If my physician is not actually laying hands on me, isn't using a stethoscope to listen to my heart, even if it's not needed for the actual kind of outcome of the treatment plan or the protocol that they're participating in, they felt like they were receiving worse care. And so that was a big thing in terms of kind of using telehealth, being kind of cautious of the kind of cultural and value implications that we have, because not all patient populations view that kind of transition of, or that one-to-one kind of quality of care. And then the last thing that we noted, which was particularly important from a public health perspective, was that our participants primarily relied on public blood pressure cuffs, such as the ones that you see at pharmacies, to monitor their disease. So as they were part of this larger study, we gave them blood pressure cuffs to be a part of the study. However, many had relatives that were not part of the study who also had hypertension, and they reported not being able to check their blood pressure because pharmacies were no longer allowing access to those blood pressure cuffs. And so in my last minute, I will run through kind of my discussion. Basically, the main thing that we kind of recommended from this was communities with high burden of hypertension should really consider increasing access to these public blood pressure cuffs, particularly in communal spaces like religious centers or community-based centers where folks can easily access them. And then virtual community building was a really important thing for alleviating stress and isolation in this population. Things like, online kind of community groups or exercise groups or something like that, making those low cost and accessible was something that was recommended by our participants. And I will stop there so that we can get some time for questions if anyone has any thoughts.
Thank you so much, Dalia, for the great presentation. Any questions? And also remember, you can always use the chat to put in your questions, and then presenters, please go ahead and respond to them as well when you see those on the chat. But really appreciate your great work in this area.
Thank you so much.
Yeah, I love
I
the
will be on
quotes.
the
I
call.
hope people can see the quotes. Yeah.
Yeah, that's my favorite part of qualitative research, is really being able to highlight the words of our participants. And so definitely urge you all to check out the poster itself. But I will be on the call if anyone has chat questions. I'll be able to answer them.
All right, excellent. So I think I'm going to switch to our third presenter then, okay? So we hope to be able to give each presenter their time. So our next presenter is Jonathan Min, and Jonathan is going to present a poster entitled Identifying Drivers of Disparity in COVID-19 Outcomes. Jonathan, thank you.
So, hi everyone, my name is Jonathan. I'm currently a student at UC Berkeley, and this relates to a project that I did with UCSF over the past summer, but under the Mindscape group. Specifically, they work on modeling infectious diseases. So this is more, I guess, of the statistics side of hopefully identifying these drivers of growth in the COVID-19 pandemic. So just to give some context, we all understand that in the COVID-19 pandemic, like a patient's health outcomes could potentially be determined by different pre-infection and post-infection factors. For example, differences in social determinants such as income, occupation, and overall socioeconomic status, insurance, and other things can result in a drastic disparity in COVID-19 accessibility to vaccines, infection, and also COVID-19 outcomes. So, for example, disease severity. By breaking down the infection timeline into different stages, our goal is to isolate which social/structural/environmental factors are associated with each component of disease progression to create better informed opportunities for action. Just to give like a quick example, for example, if there is a strong association with, for example, housing and, for example, a certain COVID-19 outcome, hopefully this can be used to inform policymakers to sort of target housing in order to be more efficient in actually addressing these COVID-19 outcomes. So in terms of methodology, we analyze different COVID-19 disease outcomes, specifically severe outcomes, length of stay at a healthcare facility, and readmission status. And the way we did so was using several multiple logistic and linear regression models to determine whether a statistically significant association existed between these factors or features and also the aforementioned outcomes. Just to be transparent, we used a single feature, the area disparity index, to sort of measure social disparity. We can discuss this later in the end, specifically the flaws with that being applied to like the national level versus a more local level. But just for this case, we use the area disparity, or this model. For simplification, we use the area disparity index, which again measures the level of a neighborhood's disadvantage as well as demographic data. And for our data source, we use the EHR data, and our model was trained on 825 patients. So some key results is just that, so we use the Charleston Comorbidity Index as a marker of overall health. And one thing that we noticed is that both race and ethnicity and ADI, specifically the Area Disparity Index, were associated with the Charleston Comorbidity Index. If you look at Table 1, specifically, it's a little bit small, but if you look at Table 1, we have a model that predicts the Charleston Comorbidity Index based off of demographic data. And from that, we could see that both whether a patient is Black has a statistically significant positive relationship between the comorbidity index, and likewise, if a patient is white, there's a negative association, and that is also statistically significant. However, when we actually include the Charleston Comorbidity Index in a model that predicts, so for example, severity at admission, we notice that the statistically significant relationship between race is actually gone, because our Charleston Comorbidity Index fully captures, or at least sufficiently captures, the information that, for example, these socioeconomic factors such as race could have in actually predicting severity at admission. So we actually noticed this additionally with, for example, a post-COVID-19 outcome, for example, readmission status. Readmission status was not associated with the Area Disparity Index, however, or was associated with the Area Disparity Index. However, readmission status was not associated with race and ethnicity. And one key thing to note is that because we use a wide variety of demographic data, our model actually accounted for a large proportion of confounding. For example, age, smoking, gender, insurance types, and BMI, and other factors could potentially confound our results. However, because we included those in our model, it minimizes confounding. And just for our general conclusion, from our report, we conclude that social determinants like race and ethnicity and socioeconomic status are associated with pre-COVID-19 health conditions. This is quite clearly seen in the sense that both race and ethnicity and socioeconomic status are associated with the Charleston Comorbidity Index, which is our quote-unquote pre-COVID-19 infection, pre-COVID-19 outcome. And as for our post-COVID-19 outcome, these social determinants were associated with readmission rates. And hopefully the main, I guess, upshot of all of this is that we have this framework of dividing the progression of COVID-19 into different components. And if we can isolate which, for example, feature or which risk factor is associated with each of these COVID-19 outcomes, we could better understand associations between these factors and these disease outcomes, and specifically target with policy how to address and alleviate these socioeconomic disparities. And I guess one thing I was thinking about towards the end, I guess just to leave off, is that specifically with regards to the models, there aren't any interaction terms. So it would be interesting to see how we could, for example, train our models with interaction terms and see whether our results would change. Yeah.
Thank you very much, Jonathan. Very exciting work. You're introducing the area disparity index. I personally definitely like to learn more about it. But I think we do not have a lot of time left, but would you mind sharing with us either at the end or maybe share more information about that, maybe in the chat if you won't mind. And everyone too, if you have additional questions for Jonathan or our prior presenters, please feel free to use the chat. I'm going to move along to our fourth presentation today. And our fourth presenter is Anna Oh. And Anna, your presentation today is on differential effect of COVID-19 pandemic on meaningful activity engagement by race and ethnicity. Thank you very much, Anna.
Thank you, Janice. So I'll just jump right in. So previous research has shown that participation in meaningful activities is beneficial to the emotional and physical well-being of older adults. And as we have all experienced, the COVID-19 pandemic altered all of our lives, including the older adults' ability to participate in meaningful activities. So thus the objective of our study was to compare meaningful activity engagement between 2015 to 2020 in a nationally representative diverse sample of older adults, 65 years and older, and the effect of COVID-19 on activity engagement. So we used a longitudinal cohort of National Health and Aging Trends study participants. Our primary outcome was participation in 4 specific activities: visiting family and friends, attending religious services, participating in clubs, classes, and other organized activities, and going out for enjoyment. And then our primary predictor was onset of the COVID-19 pandemic in these in the racial and ethnic subgroups. For our analyses, we described the proportions and characteristics of racially and ethnically diverse community dwelling older adults and used mixed effects logistic regressions to compare probabilities of activity engagement before 2020 and in 2020, after 2020, adjusting for age, sex, and other potential mediators that might affect activity participation, such as functional status, income, anxiety, depression, and transportation issues. So for our results, we found that in 2015, in our baseline, the baseline characteristics of our 6,815 participants, the mean age was about 78 years old. Almost 60% of our participants were female. You can see the racial and ethnic breakdown of our groups here. And about 20% of our participants had a functional limitation. Here it just says the 3+ of activities of needing assistance with activities of daily living. Regarding activity participation, first we found, as you can see in figure 1, that activity participation for all 4 activities remained pretty consistent between 2015 to 2019 and then dropped in 2020 as expected. And then next, we found similarities and differences in activity participation by racial and ethnic groups. So in figure 1, in the unadjusted models, you can see that among all racial and ethnic groups, visiting friends and family was the dominant activity, the orange line at the top, and that participating in clubs, classes, and organized activities was the activity with the lowest participation, the brown line at the bottom, among all racial and ethnic groups. However, the second most popular activity differed between the groups, with going out for enjoyment as second most popular activity among American Indian, Asian, white, and then participants that self-classify themselves as other. And then the second most popular activity among Black and Hispanic participants was attending religious services. In our adjusted analyses, we did find that there was a significant COVID-19 and race and ethnicity interaction in attending religious services and going out for enjoyment. We presented just those results here for the poster since they were significant. And in these series of weighted multivariable analyses, we found that for for attending religious services, Black and Hispanic participants experienced the largest decline in activity participation in Figure 2 compared to the other racial and ethnic groups, and that for going out for enjoyment, the bottom half of Figure 2, Asian and white participants experienced the largest decline. So this study provides valuable insights into the effects of the pandemic on racially and ethnically diverse community dwelling older adults. It underscores the need for tailored interventions to re-engage these older adults into different activities, and also underscores the fact that public health measures like shelter in place may have lengthened the older adult's life by preventing COVID-19 infection and death, but it may have also come at the cost of decreased participation in activities that fill the older adult's life with meaning. So that's good.
Thank you so much, Anna. This is definitely take us in addition to talking about COVID-19 related hospitalization and also telehealth management of hypertension, for example, a lot of healthcare related. And now we're talking about, various activities, and longitudinal data set. This is such a gold mine. So thank you so much. Any questions or comments from the audience? We have maybe less than a minute. I would like to ask a question, Anna, if this is okay. Actually, two questions. One is a quick one. Is the National Health Aging Trend Study only include English speakers?
No, it does not. So it oversamples for Black participants and then also does conduct the survey in Spanish. I think there is this, it's a very rich resource, but and it does ask participants if English is their first language and if they speak any other languages. But the only other language that the survey is conducted in is Spanish for the Spanish-speaking participants, and then in English.
Okay, I actually do have one more question, but I realized, Barbara, you stopped the timer, so I'm not sure if I'm on time at all.
You should probably put it in the chat.
I will put it in the chat. Thank you, Barbara. And thank you so much, Anna. Okay,
Thank you.
Let's move on to our next presentation. And our next presenter is Deborah Oh. Debbie's presentation is on neighborhood level COVID vaccination and booster disparities, a population level analysis across California. Debbie, thank you.
Okay, hello. Thanks for this opportunity to share our work. I'm going to skip over my title screen because Janice just said everything and dive right into the poster. So I think everybody has kind of already covered the fact that we have experienced a lot, or we have seen a lot of COVID-19 disparities. And a lot of the previous presentations looked at individual level data. I'm going to take you kind of like one step up, and we're looking at neighborhood level data. So we wanted to see how neighborhood factors kind of related to COVID-19 vaccination and booster outcomes. The data that we used for the neighborhood level data was pulled mostly from publicly available sources. And we looked at neighborhood factors like demographics, economic stability, community context, and health and healthcare. And so we wanted to see how these factors were associated with vaccination and booster rates. The primary outcome was a full vaccination. I know that the definition keeps changing, but we wanted to define it in September 2021, so that 2 doses of Pfizer or Moderna, or 1 dose of Johnson & Johnson. It feels like a lifetime ago, but so in September 2021, that was fully vaccinated. And that our other cut point for booster doses was in March 2022, and it was just the first booster dose. So we had the publicly available data at the zip code level, and we zipped it together with these booster outcomes, and we obtained this data from the California Department of Public Health. The CDPH has been pretty proactive in trying to think about how to utilize the data that is available, and with disparities in mind. Okay, so I'm going to take you to a zoomed in slide. And so here are two different models. So first we have generalized linear models. And first we have a minimally adjusted model in kind of like the blue teal color is vaccinations, and in the orange is booster doses. And if you can see that, so for in the blue, you can see that the proportion of Asian in a zip code, if that was higher, there was also a higher proportion of vaccinations. Same for booster doses. So a higher proportion of Asian in a zip code translated to a higher proportion of booster doses. And the reverse was true for our proportion Black, but then you see in model 2, oops, move forward. You can see in model 2, how after you adjust for all these neighborhood factors, things kind of even out. And so we see that what is driving the disparities is in fact, perhaps some of these factors listed below. The other thing that I wanted to highlight is that, from September 2021 to March 2022, a lot of things changed, but it seems like the factors driving vaccination and booster uptake stayed relatively the same. So you can see that, so let's pull out limited English proficiency in zip codes that had higher proportion limited English proficiency, they had higher vaccination uptake. Same for booster doses. The one thing that did seem to change is that population density. So population density didn't seem to come into play for vaccinations, but in March 2022, it seemed that places that had a higher population density seemed to have a higher uptake of booster doses. So it's just something that might have been different in terms of the rollout or just the mentality around boosters. Okay, so this is a very busy table and kind of hard to read, but probably even harder to read if I just only show you my poster. But what I wanted to highlight is that we have a very large and very diverse state, and that translates into very different outcomes in terms of booster uptake. And so you can see in the San Francisco Bay Area, we had 64.2% boosted in March, but in the Northern San Joaquin Valley, it's only 27.3% boosted. So you can see that there's a big difference there, but also there's just a big difference in terms of the factors that sort of that were associated with booster uptake. And I wanted to take you, so we divided the state into 10 different census regions. And so these ones that I'm showing you are kind of the northern-ish California. I'm going to take you to the next slide, interest of time, to show you just kind of one example of the differences. So you can see in, for example, the southern San Joaquin Valley, or maybe that's not the best example. Let's go to Los Angeles County. In Los Angeles County, you could see that areas that had a higher proportion of limited English proficiency had lower booster uptake. But then if you go to San Diego, if areas that had higher proportion of limited English proficiency had actually higher booster uptake. So it just kind of highlights the fact that a one-size-fits-all approach is not appropriate, especially in a place as large and diverse as California. That was actually my second point. And the first point is that these disparities in COVID-19 vaccination and booster doses are in part due to the ongoing consequences of structural racism and neighborhood disinvestment. And this one-size-fits-all approach is not going to work for a place as large and diverse as California. And it's important to look at this granular geographic data to allow identification of targetable disparities and to make local public health approaches more effective and more equitable. And that is all.
All right, thank you so much, Debbie. And then it is actually really helpful that you were able to show us the enlarged version of the table, definitely very rich data. So in the interest of time, please send in your questions for Debbie, and we're going to move on to our next presentation. We have Eva Prado, and presenting to us, hopefully I pronounce it correctly, Eva, my apology. Is it Umoja Health? Umoja Health, an action-oriented model for addressing health disparities. Thank you, Eva.
Thank you for having us here today. I'm going to be presenting about a COVID-19 equity effort that began in August of 2020 and continues until this day. A lot of the presenters have done a lot of modeling around disparities. What I'm specifically going to talk about is our approach and more of kind of an intervention rather than looking at the disparities themselves. So as we know, the COVID-19 pandemic called attention to and exacerbated long existing racial, ethnic, and socioeconomic disparities in health outcomes. As has already been presented here multiple times today, communities of color and those with limited financial and social resources have borne the brunt of COVID-19 infection and death. As you can see depicted in the graphs in the upper left-hand corner of the poster, in our own backyard in Alameda County, case and death rates have been highest amongst the Latinx, Black African American, and Pacific Islander populations. So what has the national public health response been to these disparities? For various reasons at a national level, mitigation efforts by public health entities have largely concentrated on population level strategies. So I'm talking about mandates, statewide workplace policies, vaccination, testing. Likewise, pandemic updates and information have been delivered utilizing a one-size-fits-all approach. Unfortunately, as we know, equality does not equal equity, and this general approach hasn't done much to address the aforementioned disparities. As a result, testing has not often been readily available within the most impacted communities. Vaccine uptake has been slower, and COVID information hasn't been delivered through trusted messengers. To bridge the gap between this general approach and the reality that the most impacted communities were living, in August 2020, we leveraged longstanding relationships with members of our office Community Advisory Board to build a community-based coalition of Black African American focused stakeholders in Alameda County. Stakeholders selected the name of Umoja Health, which refers to a concept of oneness. If you look in the bottom left-hand corner of the poster, you can see a graphic that depicts the original coalition, which included community-based organization, community clinics, elected officials, epidemiologists, and COVID equity staff from the Alameda County Public Health Department. In total, there was 17 original partners. In terms of our methods at the top of the poster, our primary objectives were number one, to increase access to and engagement in COVID-19 testing and vaccination in the Black African American community in Alameda County, and number two, to impact existing structural barriers to COVID-19 medication and care. We utilized a comprehensive two-prong approach. In the first prong, we convened weekly Zoom meetings open to Umoja Health partners and all Alameda County residents. Through these meetings, partners decided to focus our efforts in East and West Oakland neighborhoods where the highest percentage of Black African American residents live. They also decided to utilize a pop-up instead of a mass testing model so that we could meet residents when and where it was most convenient for them. In the second prong, we facilitated direct community-led delivery of COVID-19 testing and vaccination services. Most functions at our pop-ups and behind the scenes, including marketing, mobilization, hotline, wraparound services, registration, etc., were carried out by community volunteers from partner organizations. As you can see on the poster in the outcomes section, in the past 2 years, we've accomplished a lot. But in the interest of time, I want to point out a couple salient results of our efforts. Firstly, the number of Umoja Health partners within Alameda County alone has increased from 17 to 51 partners and now includes additional sectors. So it now includes faith-based organizations, regional health plans, municipal agencies such as the fire department and school districts, in addition to the sectors I already mentioned. We now also operate in San Mateo and San Francisco counties, and this year we began offering cancer screenings and education at our sites. Thirdly, continuous engagement with our partners in the broader Oakland community has allowed us to broaden our efforts to include advocacy and policy work. Our latest effort urged BART to continue their mask mandate, and in a matter of an hour and a half, we were able to mobilize 28 organizations and 68 individuals across the Bay Area to support this effort. So what can we take away from our approach, from our model? Firstly, it bears mentioning that we have continued our efforts for over 2 years and are one of the few organizations that still offer testing and vaccination in Alameda County. This sustained engagement with the community and our cross-sectorial approach has, number one, allowed us to serve as a trusted source of information in the face of continuously changing and often conflicting public health guidance. Number two, it's allowed us to pivot our efforts to be responsive to community needs instead of us deciding what the community needs. Number three, it's allowed community to directly engage with the Alameda Public Health Department leadership and influence policy within the Public Health Department. It has also allowed community to have direct access to actionable county data, so case and death data, which normally community members don't have access to. Lastly, it has allowed us to transcend traditional siloed approaches to addressing health disparities, which now means we can extend our model beyond COVID.
Thank you so much, Eva. I'm so sorry for cutting in because we are sensitive to our last presentation, but congratulations on the Umoja program. Very impressive. And I noticed that you also have a recording that people could get to. So thank you, Eva. I'm very sorry for cutting in. And then I would like to introduce our last
It's not Umoja, it's Umoja.
Umoja. Thank you. Congratulations to Umoja project. Thank you for the correction. Our last presentation is from Ruja Chen. And Ruja's presentations on excess mortality among older adults with Alzheimer's disease and related dementias in the United States, comparing the first and second year of COVID-19 pandemic. Ruja, thank you. Thank you, everyone. I hope you all will stay.
Can I share my screen really quick?
Sure.
Okay. So, hi everyone, my name is Ruja Chen and I'm a postdoctoral scholar at the Department of Epidemiology and Biostatistics at UCSF. So for this study, we are looking at the excess mortality among people with dementia, and we compare the first and the second year of the pandemic. And as many of us know, that older adults with dementias are particularly vulnerable to the COVID-19 pandemic. And previous research has shown that older adults with dementia has experienced substantial excess deaths during the first year of the pandemic. But as the vaccines become available to many of us and many of the preventive measures become available in the second year of the pandemic, we are trying to understand how the excess deaths changed during the second year of the pandemic and how this change differ by gender and race. So for this study, we use data from the individual level multiple cause of data from the National Center for Health Statistics. And this data covers almost all US adults. And for the populations, we use the population size from the census data. And in terms of the analysis, we fit auto-regressive integrated moving average models to monthly death count data to understand how the observed and expected death differs. So now I'm going to zoom into one of my figures. So this is one of the main results that we get. So the red lines in this figure here shows the observed deaths during the pandemic associated with ADRD, and the black lines shows the expected deaths. And as we can see, we observe significantly higher excess deaths during the pandemic related to dementias among females and also among male. And so this here represent the second years after the vaccines became available and many preventive measures became available. We saw a significant decline in SS deaths associated with dementia. And this change was similar between males and females. And we also compare the SS deaths across the racial and ethnic groups. And here is the figure shows the SS deaths associated with dementia in white, Black, and Hispanic and non-Hispanic Asian. And as we can see during the early pandemic, after the lockdowns, we see significantly higher SS deaths among non-Hispanic Black compared to non-Hispanic White, Hispanic, and non-Hispanic Asian. And then after the second years, after all the preventive measures became available, all racial and ethnic groups experienced significant declines in SS deaths. And especially for non-Hispanic White, during some of the months, the observed deaths is even lower than the Hispanic deaths. And however, for non-Hispanic Black, still see very high SS deaths even during the second year of the pandemic, suggesting that racial disparity, still persists during the second year of the pandemic. So, so our findings, these findings highlights that, especially for non-Hispanic Black older adults with ADID, they experience substantial SS deaths during the first and second year of pandemic. And even after all the preventive measures and vaccine became available, the racial disparity still persists. And so we need more public health measure to really, address the structural racism that might have led to racial disparity in SS deaths associated with ADID. That's all of my presentation. Thank you.
Thank you so much, Regia. I love the graphs that you are showing. Is really, really helpful to see these data. And thank you everyone for staying extra time. I wanted you to, encourage you to go back to the posters, also reach out to the presenters as well, and even though we may not have much time left, but we could go over a little bit if people like to have some discussion. I don't want to cut short, so my apology again for the great work that everyone is doing, such important work in the area of COVID-19 and health impacts. It definitely takes a village, both communities, health systems, and not to mention about a lot of important neighborhood measures showing various disparities. So thank you, everyone. And so we will have the recordings available as well, and so that you can also reach out to all the presenters. Thank you so much, everyone, for sharing your important work.
Thanks, everyone. And it takes us usually about a week to get everything up and loaded on the diversity site, but we will have a full playlist for the symposium, including all the breakout sessions.
Wonderful.
Thanks.
Thank you, everyone. Thank you for your great work.